So just while they leave, I'll take a few moments to introduce Professor Michael Quinn. He is well known, I'm sure, to many in the room. So he's from the University of Melbourne and the Royal Women's Hospital in Melbourne, and has been part of the gynecologic furniture for as long as I've been around, and that's since the 80s, so that's quite a long time. Since I was a medical student, I could go so far as to say, near the age of 50, I'm probably here because of Professor Quinn. And having introduced that concept, I want to give you my earliest memory of him. We were in the very, very old Royal Women's Hospital. It would have been my first day in my gynae-onc term. And there was Professor Quinn standing beside a patient in a bed. The patient had cervical cancer, and he was her champion. I can't ever forget that, really. And that's the concept of medicine that's been imbued in me that I think we have very strongly in Australia. He is president-elect of IGCS, so he's operated at the very top international levels, again, probably for as long as I can remember. And contrary to what many in the field have done for the last 30 years, he's had a long-standing interest in the immune system. Now, you hear a lot about it at the moment, and it's really, even more exciting than PARP inhibitors right at the moment, but that was not always the case. Anyway, he's pushing me off the stage, so...
Okay. Thanks very much, Claire. Ovarian Cancer Australia, IGCS, thank you for inviting me here. Ovarian Cancer Australia started in 2001, as you know, and Sheila Lee was my patient, and I just think that if Sheila was here, she'd be so proud of what you've achieved, and congratulations to you. Claire, I just got to say, and thank you to the first three speakers, because I've never seen Claire quiet after a talk. It's the first time I've seen her actually short of words, so well done, and we could use you again. Now, I know we're running behind, so I'm going to leave a few things out, but I'll try and cover stuff as much as possible if I can get this to work. Claire? No, it's dead. Okay. It was working? Maybe my champion can help me. Okay. I'm going to just talk about ovarian cancer because this is Ovarian Cancer Australia, and I'm going to challenge you, and I'm going to challenge Ovarian Cancer Australia a little bit about why we are not so good at looking after women with ovarian cancer. So we're going to talk about simple ways that we can actually improve outcomes for women with what we've got, because we don't do well with what we've got in Australia, and we need to improve on that. I'm going to briefly talk about prevention, a very important issue. I'm going to try and be realistic about personalized medicine, about having your tumor assayed for mutations and having a magic drug that's going to cure you of your cancer. And finally, I'm going to talk about something that is close to my heart, and that's about immunity and cancer in general. So how are we doing? And this is a slide, and we're down here in the blue, and compared to many centres in the world, this is our survival in Victoria for advanced stage cancer, and it's 34%. So we are 10% worse, 1 in 10 women, worse than British Columbia. Now, why is that? And I was very interested in Eric Poujade-Lorraine, that gorgeous Frenchman that you heard with a wonderful accent. All the ladies were purring. I saw you purr. And what they've done in France is they've centralized cancer centers, and you saw that from his slide. And I think that's probably, for me, one of the things that we need to talk about in this forum. Because what every patient with ovarian cancer wants is cutting-edge care. When I say to them, here's a list of 10 things, rank them, the things that they say to me are, I want cutting-edge care, cutting-edge care, cutting-edge care. That's the number one. Anywhere in the world, if I was there, I want you to be able to provide that for me. And I don't think we're able to do that at the moment. Now, this is one of these horrible slides. I don't want you to look at it. It's all about the fancy stuff that Claire does, that Eric does, and all the rest of it. It's about targeted agents. And I think that we should be optimistic. I think we will get to the day when we will stop using blunderbuss chemotherapy, and we will be able to use agents that can be given by mouth, that will have far less side effects, and more importantly, will actually be able to cure this disease. So I think we should be optimistic because we, particularly in the last 5 years, I think are making great progress. This is Michael Friedlander's slide. He's coming to talk to you this afternoon. He's a great guy, and what he has done is said, well, listen, what we've got at the moment, how can we improve on that? And these are all the things that we've got: debulking surgery, making sure the pathology is right, selecting patients for trials, optimizing chemotherapy, and so on. And I'll talk first about optimizing chemotherapy. That means that if your doctor wants you to have 6 cycles of carboplatin and Taxol, What are the chances that you're going to finish that? What are the chances of you actually getting that combination? Because you may go to a doctor who gives you single agent carboplatin. Why is that? What about debulking surgery? When you go to a center and you have a surgeon who's doing your operation, how do you really know that surgeon's actually the right person to do your operation? And why it's important is this, and this is a slide which just so shows on the right, and this is women with advanced cancer, that if those women do not get standard treatment, then they are less likely to survive their cancers. And this is an American study, and in America they have major cancer centers, but they've often got small rural cancer centers where patients have off-standard therapy treatment, and those patients are less likely to be cured. Now, what about Australia? And this is hot from the press, and you mustn't quote this because it isn't published, but it's been accepted for publication, and Claire knows about this. And basically it shows that in Australia, if you get less than 70% of your planned dose of chemotherapy, you have got a much worse chance, a much lesser chance of surviving. So if you don't get the right treatment, or you don't get enough of the right treatment, you're going to be sorely disadvantaged. Australian data. And when I look at my own unit in Melbourne, we just said, well, if you went into a clinical trial, how is that going to help you? It didn't improve your chance of survival, but what it did was it made you live longer. So I'm going to plug clinical trials. Monica is the queen of international gynae cancer clinical trials. You can see that every slide I've got has got the gynecological cancer intergroup, and that's because she nags me about it. Very important. And finally, this is surgery. Down at the bottom, unfortunately, are patients who get, for whatever reason, a large amount of cancer that's left. And up the top, you can see the survival if you can remove all the cancer. A huge difference, like 60% difference. So the most important thing is your upfront surgery and get the right chemotherapy, and then finally go on to a clinical trial. And that's the way to move forward in ovarian cancer for me. So what can we do better? We need to adhere to guidelines. We need better surgery. And one of the things that we need to do in Australia, I believe, is that we need to start accrediting surgeons and accrediting medical oncologists. And there are no radiation oncologists here, but them also. We need to get better chemotherapy, obviously, with better supportive care, and also looking at those complementary areas. And then finally, better access to clinical trials. But how about prevention? Do you love this, Monica? I've got 2, 4, 5, 7. That's a record. Okay, you happy? Prevention is really important. We're able to prevent cervix cancer because we've got a pap smear. We now have a cervical cancer vaccine introduced by a Scotsman in Australia, very important. But just while we're talking about cervical cancer, a huge statistic that we heard yesterday in the brainstorming that we had about prevention of cervical cancer. With all this that's going on with Ebola virus, 750 women every day in the world die from cervical cancer. 750 women every day. And we've got all this hoo-ha about Ebola virus, but we don't have any hoo-ha about HPV, the human papillomavirus. And as Dr. Gaffney said, only 50% of young girls in the United States who should be vaccinated get the actual vaccine. Completely preventable disease now, we hope. Okay. Now, chemoprevention is very important, and this is about aspirin, and we know, and I take aspirin for this reason, that aspirin has been shown to reduce your risk of getting bowel cancer. And it works by being an anti-inflammatory agent. So what has happened is that they've looked at all the studies in ovarian cancer, and it seems clear that women who take aspirin on a daily basis have got a reduced risk of getting ovarian cancer. Now, why might it work? How is that possible? Well, I don't know if you've heard this morning about the ideas that epithelial cancer, the cancer starting in the surface of the ovary, actually arises in the fallopian tube. And it's that change in the fallopian tube with the cells spilling onto the ovary or the tube sticking onto the ovary and an inflammatory process developing and cancer developing rather than it starting on the ovary itself. And I think that's where we are at the moment, although there are other ideas on this. But it's an important observation. So the idea is that if these cells are there and they are actually going to get to the ovary and cause a cancer via an inflammatory process, by giving aspirin, that might reduce the risk of a woman getting cancer of the ovary. It makes sense. So the first study is going to be in women who are at the highest risk of getting cancer of the ovary. And those are women who carry mutations of BRCA1 and BRCA2. And those women we know have got around about, what's the current in situ fallopian tube, about 15%. So about 1 in 6 to 1 in 7 of those women will have these changes in the fallopian tube. And how do we know that? It's because we remove them. And that hopefully aspirin just might be able to reverse those changes. So the idea is that when a woman is scheduled to have this surgery, having her tubes and ovaries removed because she doesn't want to get cancer in the future, the study will give those women 6 months of aspirin or 6 months of a placebo tablet, and then when she has her ovaries out, we'll be able to look at the fallopian tubes and see, is there any in situ inflammatory cancer starting in the tube, or has the aspirin been able to reverse this? So it's early days, but I think it's a particularly interesting concept and one that we should be pretty happy about because it's a nice, easy thing to do. 1 tablet of aspirin, which I take every morning. It's great. Now, what about all the stuff that Claire loves? Claire is the queen of molecular medicine. I'm going to show some of her slides. And what is precision medicine? And basically, it's just small molecules that are involved in either signaling, saying to the cell, I want you to switch on and divide, or where the actual DNA, there is a mutation, a fault in the gene sequencing, or downstream of that. And so everyone now believes that this is going to be the way to go, but this is just one pathway. So how do you select out of this conglomeration of pathways to get your drug and to do a clinical trial? And these are more pathways, and these are more mutations. So as doctors, as clinicians, and as now scientists, how do we actually home in on these and translate that into the community so that we can cure more women of ovarian cancer? It is a major challenge. And to make it even more difficult, when you have a cancer of the ovary, we think now that the mutations in your primary cancer are going to be different to the mutations in the cancer that spread. And with time, when you get a recurrence, the mutations are also going to be different. So it's a changing field. And what that's led to is this idea that we need to actually try and get cancer, the tumor, when it recurs, so that we know what mutations we're going to deal with. And these are just some of the mutations, and you can see there's a huge amount. And that's possible, but one of the problems we have is that if you have a mutation in your recurrent cancer and we give you a targeted drug, some of those targeted drugs don't work. And is that because as the tumor is evolving, the drivers of change in that tumor are making the drug ineffective? And it's early days and we really don't know. But what we do know is that to answer the question, we need to get multiple samples. And that's really tough. You get a recurrent cancer of the ovary, and someone has to put a needle or a core biopsy through your tummy usually, or through the top of the vagina to get a sample, and that's a big ask for women. But needless to say, women want to have this done because they want to try and improve their outcomes. Other problems, very expensive. The availability of these drugs. Okay, I've got something wrong with my tumor, there's a genetic alteration. Is there a drug out there that I can use? Sometimes there is, and sometimes there isn't. And that's very disappointing. Because if you say to a patient, I found a mutation in your tumor, but there's no drug available, that is a huge letdown. So we have to manage your expectations. We've got to make sure that you are consented, you understand exactly what are the pros and cons of you going into a study like this. And it's tough for us, believe me, because we love to give good news, but it's really hard when we have to give the bad news. But I don't think it's all doom and gloom. And in Victoria, I'm going to give a plug for the local group. We have a study with the Claire's involved in, myself, a number of centres, in which we're getting recurrent tumour sample, and then we are looking for these specific mutations, and then we have said that as of 2 weeks ago, that the eligibility to go into this program will be the first time a patient has a recurrent cancer. So you have cancer of the ovary, you have your primary treatment, and if it comes back again, that's the time that we want to move those patients into this particular study. And I think there is more good news, and I'll finish with immunity because it's close to my heart. I was the first research I did, first research I did when I was in Scotland was about alcohol. Groundbreaking. But the second thing I did was I was looking at how the lymphocytes, the cells in the blood that are involved in immunity, how did they respond to the operation we did for ovarian cancer? And what we found out was that surgery of all types reduces the ability of your white cells to respond. So that switched me on, and I've had interest in that since. Now, we've got two sorts of immunity and approaches. We've got the generation of antibodies, and that's how probably vaccines work. But we've also got the cells, the killer cells. And these killer cells are fantastic, and they would work all the time, except we've got bad guys. We've got cells that are called regulatory cells, and these stop the killer cells killing off the tumor. So if you can knock off the regulatory cells, the bad guys, then that's going to allow the good guys to work. And this is just something that's close to my heart at the moment. I'd love to boost the immune system, but I don't know what it means, and I don't think we've got anything that actually boosts the immune system in 2014. I think cancer is an immunological disorder. I think it does evoke an immune response. And this is a horrible slide, but what it says is if you've got a cancer in your ovary and there are white cells homing into that cancer, tumor-infiltrating lymphocytes, tumor-infiltrating white cells, that your outcome, no matter what I do as a surgeon or you do as a medical oncologist, it's going to be better if your immune system has got those cells in the tumor. And what they've done in recurrent cervix cancer is fantastic. They've just reported a very small study of 5 women with recurrent cervix of the cancer, which unfortunately is always fatal. And they've taken these cells from the recurrent tumor, the lymphocytes, they've grown them and reinfused them into those women with a drip. And 2 out of those 5 women are alive without cancer 18 months later. That is unbelievable. So it says the concept, the importance of immunity is really, really important. This just reinforces it with ovarian cancer, that if you have these tumor cells, your 5-year survival was nearly 40%, but if there weren't any there, you were not able to do very well. And we actually now, with Claire's work and David Bautel's work, are able to recognize at a molecular level the subtypes of these high-grade serous, and we can actually pinpoint which are the immune-type serous cancers, and we know they've got a much better outcome. So what we've done in a women's hospital is that we've looked at how is it that if you knock off these regulatory cells, how are they going to work? And it looks as if it's through what they produce, a cytokine, something that is a cell signaler. And as a result of the studies that we've done, and I'll just show you one patient, because you always show your best result, but we have just started a longitudinal study. We've got a PhD student who's going to follow hopefully 30 patients with high-grade serous tumors. And as part of that study, we're going to have tumor samples that are going to Claire's laboratory, they're going to many laboratories, but we are going to measure that woman's immune system before the cancer is removed, after it's removed, before every treatment of chemotherapy, and then every 3 months when she's been followed up. This has never been done before for solid tumors. You can't believe it's the most simple study, very reasonable idea, and I think it will give us a lot of answers. Can we boost the immune system? And is it? Chemotherapy doesn't only kill cells, but has got a beneficial effect on knocking off the bad guys. So what we did was, and you can't read this, I'm sorry, what we did was we took a bunch of women who very kindly agreed to go into our immune study. I mean, they were fantastic, and they were women with very advanced cancers. And we said we wanted to see if we can switch off your bad T cells, the things that are not allowing your killer cells. And we used a very low dose of a tablet called cyclophosphamide. It's an anti-cancer drug. And we used a dose that was about a 50th of what we normally would. And we gave it for 3 days, and then we looked to see if there was any response in the immune system. And this is one patient who went on to that treatment. She was a young woman. She had recurrence in her lymph glands. It wasn't inside the tummy cavity, as just ovarian cancer usually comes. And you can see here our CA125 went down to normal, and she had a magnificent response for over a year from this very low dose chemotherapy. And we think it's not working by killing off the cell, it's working through the immune system. And we think it's through this signaler called CCR4, chemokine receptor 4. And when we looked at the patients who did very well in this study, the 4 patients who did really well were the patients who were able to produce this cytokine, this signaling that was able to switch off the bad T cells. So I think for us that the immune system is definitely something that we are happy that we should be exploring further, and that with the study that we're going to do, hopefully we'll be able in 3 years' time, because it's going to take 3 years, to answer some of the questions. I've got a few more slides, but I think I'll stop there. It's lunchtime, and I'll be happy to answer any questions. Okay.
Thank you, Professor Quinn. Would anyone like to ask him a question or two before breaking for lunch? Up the back.
But I did look at it back in my PhD days, and there is a body of evidence that clearly demonstrates exercise improves, boosts the immune system. So I'm wondering why. Is there a particular reason why you're not counting that as kind of good information?
Okay, I'm very interested in exercise as well because I run marathons, and it's a very important part of my life. And you'll hear this afternoon that exercise reduces the recurrence rate of some cancers, and the data is really very strong. It depends on the amount of exercise. Elite athletes actually have got rotten lymphocytes. They don't work well at all, and they're more liable to get chest infections and all the rest of it. But non-elite athletes like myself have good lymphocytes, and hopefully part of the program, the prevention of ovarian cancer, will involve exercise, and I know that's what you're going to be talking about because I think it's a key. I think there is good Australian data that excess weight is associated with what are called mucinous cancers, the non-serous type. So I think if we can get our population to think about losing weight, they'll reduce uterine cancer, they'll reduce some sorts of ovarian cancer, and they'll reduce breast cancer. Exercise.
Perhaps if I just say, I don't run marathons, but I was over there muttering exercise at that point, Sandy. I was just being a bit dutiful, and I also thought you were probably talking about not knowing which subtypes of the immune system were going to be boosted. I mean, I couldn't, back what Sandy's saying more. And even for people who aren't in a formal exercise program, walk for half an hour to an hour a day is what I tell, all of my patients. And Sandy will give you a much more precise rendition of the story than that. But if my words are just a general positive in that direction, I think that's a good thing. So I think we should also eat as well as exercise, so we should break for lunch, but thank you very much for your attention.